Now we can start. We were waiting for Willie and Andrew, but oh well. All right, just going back in time. This is probably the beginning of Module B from 1050. We know that there's three different driving pressures which are present. The transthoracic, the transpulmonary, and the transrespiratory. Transthoracic is that first one that's across the chest wall. The difference between the alveolar pressure and the intrapleural pressure is transpulmonary, and the sum of them together is the transrespiratory. And again, just graphically looking at the change that occurs as we have a breath beginning on a spontaneously breathing patient. You have a negative deflection, causing intrapleural pressure drops first, causing alveolar pressure to drop, causing inspiratory flow to occur and volume to be attained. And then on exhalation, the alveolar pressure becomes slightly positive related to atmospheric because there's a pressure gradient now exists, airflow moves out, and the patient basically exhales at that point in time. We know that the two key factors associated with this are the presence of airway resistance and the presence of compliance. As far as resistance is concerned, that's a non-static condition. It requires airflow to happen, and it's based upon Poussin's law. It's that inelastic component of lung expansion. The abbreviation RAW is what is used for airway resistance, and we know it's the change in pressure over this flow in a normal spontaneously breathing patient, somewhere around 0.5 to 2.5 centimeters of water per liter per second. We also know that as lung volume increases, airway resistance decreases, so that on inspiration, as you're taking a breath in, the dilation of the airways themselves causes a reduction in airway resistance. This is why most wheezing that you hear audibly is occurring on the expiratory phase, because the airways are dynamically smaller at that point in time. And we know that as airway resistance rises, so does the work of breathing, and that is one of the reasons by which we end up having respiratory failure occurring is due to an increase in airway resistance. Some of the things that can cause that you should be aware of, primarily we think of bronchospasm or some other cause of the airways being narrowed, increased secretions, increased edema, but it also can be a foreign body obstruction. Simply placing it in the tracheal tube narrows the diameter of the airway. And there's also things that we can do to the ventilator circuitry. When we talk about HMEs later on this afternoon, we'll end up seeing that there is one of the problems of HMEs is that they can become soiled, wet, and when that happens, the airway resistance goes up significantly. Can also have changes outside of the airway, either outside the wall of the airway or the wall itself, usually associated with tumors. So, and then there's Poussin's law, which is basically looking at flow through a tube as it's related to the flow is directly proportional to a pressure differential in the radius. We normally look at the second formula more so as far as what kind of pressure drop is required, and where radius is in the denominator in this case, that's the significant component that we end up having. As I reduce the airway by half, the flow required to maintain a constant pressure has to go up by 16. So here I end up having my radius decrease by a half, and the driving pressure required to maintain a constant flow has to go up by a factor of 16, which is basically what I just said. Looking at it from a different way, in that if I reduce the radius, not in this case by half, but as I reduce the radius, in order to maintain a constant pressure through there, the flow rate has to be cut in half. So there's a relationship that exists between those three variables. Actually, we don't look at the length or the viscosity. We're assuming that those are kept constant. but they can also play into this. So here's a kind of question that you might see on a written evaluation tool, say, I don't know, Wednesday. You got a pressure of 3 centimeters of water, a flow rate of 5 liters per minute. What's the air resistance? And in this case, remember that we want to have in centimeters of water per liter per second. So first of all, you have to convert that 5 liters per minute to liters per second. Then you can go ahead and plug it into the formula, and you find out it's about 36. Cool? Sure, whatever you say, Rick. Looking at the other end of the spectrum of the compliance, which is lung at rest, and this basically is the natural tendency of the lung to want to collapse inward, the chest wall to want to expand outward, and the relationship between those two forces going in opposite directions is what establishes the FRC, and that elastic property is known as compliance, with its reciprocal being elastance. It's basically how easy or hard it is to inflate the lung. So the resistance to it, I don't want to use the word resistance, the tendency of the lung to not want to resist expansion. How's that? And the formula for lung compliance is change in volume over change in pressure. Normal lung compliance is somewhere around 100 milliliters per centimeter of water, meaning if normal intrapleural pressure change is about 5 centimeters of water, which it is, then there would be somewhere on the order of 5 times 100 or 500 milliliters of tidal volume generated. Makes sense. And obviously, as the lung compliance gets poorer, as that curve goes towards the horizontal axis, the amount of work of breathing goes up also, and that's the other reason primarily we see respiratory failure occurring. Elastance is the tendency to return back to normal, a spring that returns back to its normal shape. We know that as we overdistend a substance, it gets to the point where the elastance becomes so great, where the stretch becomes so much that we end up reducing its ability to return back to its normal shape. And that's what ends up happening when I have increased airway pressure, trying to inflate the lung. There comes a point at which the lung can no longer sustain that amount of distension, and you end up having a rupture to the lung itself. So this is giving us an example of measuring compliance. Again, a kind of question you might see. 800 milliliters, changing that to liters, 0.8 liters, and then plugging into the formula, we'd end up with 0.033 liters per centimeter of water, or 33 milliliters per centimeter of water, depending upon what units you're asked to calculate to. This is all old hat, right? None of this is revolutionary thus far. So Wednesday should be an easy test, right?
No.
Are you saying that I can make things difficult, Kathy? Okay.
Yes.
Just checking. Now, there are 2 different measurements of lung compliance, and I can't remember if we talked about this previously or not. Dynamic compliance and static compliance. We're going to focus primarily on static, but you should know the concept of dynamic. This is the formula we're going to utilize now. It's a little bit of a twist from what we looked previously, but it's saying that the static compliance is equal to the corrected tidal volume, key word there, corrected tidal volume, divided by a pressure change, and in this case, the 2 pressures are the plateau pressure and the baseline pressure. This is telling us what the elastic component of ventilation is. Okay. Corrected tidal volume divided by plateau pressure minus baseline pressure, or PEEP. Yes?
What is the corrected tidal volume? What is that?
I can't tell you yet. We'll find out in a little while that when the ventilator delivers a breath, not all of the tidal volume that's coming out of the machine necessarily goes to the patient. Some of the volume is lost as the circuit distends. We call that compressible volume. We have to account for that compressible volume and take it into account. Otherwise, our measurement's not going to be accurate. Okay. Nominally, it's not a lot of volume. On a 500 milliliter tidal volume, it might be 60 milliliters. Big deal. But when you're talking about a neonatal patient where your tidal volume is 7 milliliters or 6 milliliters, any amount of volume loss can be critical. Okay. But that's corrected tidal volume. Okay. We'll talk more about that when I talk about compliance.
So the diameter expands.
Yeah, and when you I don't know if you noticed when you were doing IPB, but basically as the pressure rises, the circuitry itself actually becomes larger because you're not only inflating the lungs, you're basically distending that circuitry because the plastic has the ability to be changing shape.
Would that be mechanical compliance?
No, it's called compressible volume. And it's determined by the compliance of the circuitry itself. Oh, good God, no. So the stiffer the tubing, the less is lost. Yeah, the stiffer the tubing, the less volume is lost.
Well, it's like any other area.
It definitely is, yeah. So that's static compliance, okay? The other type of compliance that exists is known as dynamic compliance. And this is, back up a second here. This key part here when you measure static compliance, the way that we create this plateau pressure is we have a small pause that is created at the end of the inspiratory phase. Yeah, so I deliver a breath, I pause, and then the patient exhales. During that pause, the pressure that's in the circuitry is allowed to dissipate across the entire lung circuit model. Okay? So any pressure that exists in theory in the alveolus would be equilibrated with what is at the airway. That's the premise that we're going under here. That plateau pressure that we're measuring is equatable to what the alveoli are feeling. Okay? But there's a pause that is created. In the case of dynamic compliance, there is no pause. All we're looking at is the peak pressure less the baseline. From a clinical standpoint, this value doesn't really help us. Okay? It's telling us how much pressure is required to inflate the lungs. Okay, that's nice. But it doesn't tell us how much of it is resistance, how much of it is compliance. Static compliance tells us specifically how much is compliance. I've got another slide on this later on, but I'll draw one for you now. When I inflate my lungs, I go to a peak pressure. I then cause a small pause to occur, and I generate my plateau pressure, and then I return back down to baseline. This would be baseline, or what we're going to call PEEP. So far, so good? Now, if I can draw this straight line from there to there, this part is resistance. This part is compliance. And this will make more sense in about an hour. Maybe. Maybe not. Okay. But there's some component of inflating the lungs that is due to resistance, some related to overcoming compliance changes. When I'm measuring dynamic, I'm looking at the peak minus the baseline. I'm looking at the total thing. Well, it's the combination of both compliance and resistance. Doesn't tell me much. So again, clinically, it's not something that we really pay attention to, but from a testing standpoint, you may need to know that.
Are we considering PEEP as the baseline?
Yeah. For right now, we're going to use the term PEEP and baseline interchangeably.
Okay.
Yes, and in about 2 minutes, we'll talk about peak and plateau and the interrelationship between the two of them and how I can use them to determine if it's a resistance problem or a compliance problem. Absolutely. Okay, so that's dynamic compliance. Peak minus baseline. Now, when you have a rise in pressure, I think this is where Kathy was going, you either have a change in resistance or a change in compliance. Either the airway resistance has increased, and that's what's causing a higher pressure required to ventilate that patient, or the lungs have become stiffer, requiring a higher pressure. So in volume ventilation, which is typically what we use in most ICUs, is a volume approach, and I'll touch back on this in a second. But I think Jeannie might have talked about it briefly when she talked about mechanical ventilation. Yes, no? Little bit, good. But we look at the peak and the plateau pressure. If you have a situation where I'm ventilating and my ventilating pressure is, let's say, 25 centimeters of water is a peak pressure, I have to write down those numbers. Let's say at 10 a.m., I go in and I look at my peak pressure is 25. My plateau pressure, let's say, is 20. Noon I come back, and my peak pressure is 35, and my plateau pressure is 30. My pressure increased during that duration. My peak pressure increased, and the plateau went up with it proportionally. In fact, in this case, it went up exactly the same amount. Doesn't have to be. But if they both go up together, they're both holding hands, it's a compliance problem. They're compliant. What this is saying is when I inflate that lung and I allow a small pause to occur, the lung being stiff itself transmits that increase in pressure along with the peak pressure. So the static goes up together with the plateau in the process. Okay. That's why they're there. Make sense? Okay. Second scenario. At 10 a.m., my peak pressure was 25, my plateau pressure was 20. At noon, my peak pressure is 35, my plateau pressure is 21. Peak went up, plateau did not. In that case, that's a resistance problem. When I have that pause occurring, the pressure in the airway is allowed to spread itself out across the lung. Meaning, given time, even though I got a narrowed airway, gas is allowed to spread itself out. And the pressure doesn't rise in the same fashion in the plateau that rose in the peak. Peak and plateau both go up, compliance problem. Peak goes up, a plateau doesn't proportionally, that's a resistance problem.
So it doesn't matter that it just went up one, it needs to be more drastic?
Yes.
It could be a compliance
Yeah,
problem?
they need to go up kind of together. And you'll never see a situation where it's kind of in between. It either goes up, they both go up within one or two, or they don't go up within one or two.
Is the opposite true? If they go down,
Yeah,
so if they go down together, it's still a compliance problem?
it's compliance improving. If peak goes down and plateau stays the same, then resistance has improved. Airway resistance has been reduced. Yes.
So even if they both go up or down, so this is a compliance problem, they both go up or down within like one or two, is that still gonna be, or does that just not happen?
That's not saying much of anything. If you're going to see a rise in pressure, you're going to see a pretty substantial rise in peak pressure. You then look to the plateau. Did it go up with it or did it not?
Okay.
bottom line, if you're ever in doubt, what do? You calculate it. You don't call me. I'm useless.
Logical thing to do.
And you'd be surprised how many times I get an email or a text message or Facebook message or whatever saying, "Hey Rick, what's that formula again for determining predictive title?"
Check Cybers.
Yeah, exactly. All right, so resistance and compliance. Need to distinguish between the two of them because I'm walking into the ICU and I'm seeing my high pressure alarm going off. Which is it? Because the solution for a compliance problem is totally different than a solution for a resistance problem. So here's an example of a kind of question that you might see on Wednesday or thereafter forever. Peak pressure is at 30, plateaus at 20. An hour later, peak pressure is at 45, plateaus at 22. Peak pressure went up by 15, plateau went up by 2. Resistance problem. Okay?
So, but what is the cause?
You tell me.
So if the
Could be bronchospasm, mucus plug secretions. No. No. What else though?
Edema,
well, your ventilator,
Edema how?
causing a narrowing.
Okay. Part of that asthmatic picture. Okay. Biting on the tube. Those are all things that can possibly cause airway resistance to be increased. So graphically, this is again that kind of picture that I drew for you. But here I have a situation where my peak pressure looks to be, I don't know, this is probably about 40, plateau's about 20.
why is there a drop?
I'm sorry?
Plateau. From your peak to your plateau, why is there a little drop?
Because during that plateau time, during that pause time, the pressure that's inside the circuitry is allowed to spread itself out. And in a case of a stiff lung, it's not going to be able to move much. In the case of an airway resistance problem, it's allowed to spread itself out. But here, peak went up to, say, 60, plateau went up to 40, that's a compliance problem. Here my peak's at 40, peak goes up to 60, but plateau doesn't change, that's a resistance. And I believe that's somewhere out of your, out of Pilbeam, or Cairo, whatever, your text. Which, by the way, now is going to be the time that we're going to start looking at the book. So, just to warn you. All right, deep breath. When we ventilate a patient, there's 3 variables that we basically have to work with. You can't see that. How about if I change this to white? Volume, pressure, actually got 4. Flow, and time. Those are variables that we can manipulate. Those are things we can play with. And they're interrelated. Okay. What we need to do is say, you know what? I'm going to control one of them, and everything else will become a variable. You can only control one thing at a time. Despite the fact that we like to think we can control multiple things, you can't. When we're ventilating somebody, we either control the amount of pressure that the airways are exposed to, or we control the volume that we desire to put in. And I'm using these terms very specifically because you can get confused really easily. Yeah, right. Pressure-based breaths mean I keep the pressure constant. The volume and the flow then become variable. Examples of this are your IPBB machine that you had, or in a mechanically ventilated patient, something called pressure control ventilation or pressure support ventilation. Or in the neonatal world, we use a time constant pressure limited ventilation, which is what that silly thing means there. But we'll come across and get deeper into what each of these is as time goes on. But IPB you know about. Yes, Steve.
Why can't you control volume and time together?
You do in a sense that what is the definition of flow? Volume over time. So volume, time, and flow are all kind of interrelated. Pressure's kind of by itself. But when you control pressure, you're allowing the airways to be exposed to a specific pressure for a specific time, yes. But it's the pressure-based component that we're controlling pressure in the process. Volume and flow then become variable. Okay. So I expose the airways to 30 centimeters of water for 0.8 seconds. What tidal volume is being generated with that breath is dependent on what? The time I'm locking in. Time does have some component to it. Resistance and compliance. Okay. Those are the two things that affect how much volume is generated. Other end of the spectrum, let's keep volume constant. A volume-based breath. In a volume-based breath, the volume is going to be the same each and every breath, regardless of the resistance or compliance. What's going to be the variable in that case? Pressure. You guys probably saw that when you were delivering your IPBB, a pressure-based breath. You change the amount of pressure, you change the tidal volume delivered. I don't know if they manipulated the compliance and resistance of the lungs, but that'll do the same thing. Okay. So when you walk into an ICU, the patient is either being ventilated with a volume-based approach or a pressure-based approach. Which is better? Yes. Doesn't matter. What matters is that the person who's operating that machine understands what will happen when compliance and resistance changes in each instance. Okay? Majority of people learned, let me rephrase that. The majority of people trained in the United States learned volume-based breaths. That's what we always used. Go outside the U.S., go to the pediatric area, they're more pressure-based. What is interesting is that now, 30 years later, we've kind of flip-flopped, and more and more we're seeing pressure-based breaths in the ICU, and in the neonatal, we're looking at not necessarily a volume-based breath, but certainly volume is an important component. Okay. So let's go back through these two scenarios so I got a little bit better of a handle. When I am giving a volume-based breath, I as a clinician am setting a specific tidal volume I wish to be delivered and at a specific flow. We're going to set what is called the peak flow rate. Those two parameters are dictated by us. The pressure generated during the breath is dependent upon the lung compliance, the airway resistance, and to some extent, the shape of the flow pattern, which I'll just say that and we'll talk about it later. So I'm throwing a lot at you today. Okay. So what happens if my compliance improves? And a volume-based breath doesn't require as much pressure. What happens if my compliance falls? I develop a pneumothorax. I develop congestive heart failure, and all of a sudden my lung compliance stinks. The airway pressure is going to go up. Resistance are kind of the opposite. As airway resistance goes up, airway pressure's got to go up. I'm putting that same volume through a tube that's narrower. It's going to take more pressure to push it in. If resistance improves, airway pressure goes down. What does not change is the tidal volume or the flow. I'm setting those. I'll be damned if they're going to change.
So when you're thinking of compliance and resistance, you're always gonna deal with the pressure going up and down.
In a volume-based breath.
When the opposite was used in the pressure.
Include that last statement. In a volume-based breath. It's key. Dana.
If you had a patient that was like awake and fighting the ventilator, would they receive a higher tidal volume then?
No. Tidal volume is fixed. There's all kind of other things that would end up happening. They probably would require a higher pressure because they're fighting against it.
Okay.
Kind of like the resistance issue. Yeah. So in a volume-based breath, I dictate the volume and I dictate the flow pattern and flow rate. I'm delivering gas at this speed. I'm delivering this much of a breath as far as the size. What's going to vary is going to be the tidal volume. The airway pressure. Okay. Got volume-based? Pressure-based. Here, I'm setting a delivered pressure and an inspiratory time. So I'm exposing the airways to 25 centimeters of water for 0.1 or 0.8 seconds. And what tidal volume is delivered is dictated by the compliance and resistance. Volume and flow are variable depending upon the compliance and resistance of the lungs. As compliance goes up, compliance improves, the amount of tidal volume gets better. This is why in neonatal we had to be careful when we gave surfactant. You give surfactant and all of a sudden the lung becomes far more compliant. That same pressure is going to generate a bigger tidal volume. That can be a bad thing. Okay? As compliance falls, tidal volume falls. This is our IPVB machine. Get a stiff lung, now all of a sudden the tidal volume being generated is less. Resistance is obviously the opposite. What doesn't change out in this case is airway pressure. Because I'm setting it. It's going to be fixed. Is this making sense or am I just beating a dead horse here? Okay. Kind of, I'm getting looks like.
It's Monday.
That may just be. I was just saying, it may just be Monday. So it's critical to know what the origin of that breath is, because how I'm going to respond to changes in patients' lung compliance and resistance is dictated by the type of breath I'm working with, as far as what I can end up doing. We know that alveolar minute ventilation is related, is how PaCO2 is dictated. We know that as I increase the minute volume, I reduce the arterial carbon dioxide level. Opposite is true. If I decrease minute volume, CO2 rises. We know that that minute ventilation is a component of a tidal volume less some amount of dead space volume, where that dead space is anatomic, that doesn't change. And how do I determine that? 1 milliliter per pound of ideal body weight. Okay, so a 150 pound ideal body weight person would have approximately 150 milliliters of anatomic dead space. Does not change. It's always there. There's also, though, mechanical dead space, which is stuff that we add on between the ventilator Y and the endotracheal tube. Anything you put in that space is considered mechanical dead space. And the other one that is there, and by the way, that should be a V, and that should be a Q. it a V and Q on yours? Or is it a box? So in other words, areas where I have alveoli that are being adequately ventilated but are being underperfused. When ventilation exceeds perfusion, we call that a dead space. Alveolar dead space specifically. So the combination of this VD, you have to take into account anatomic, mechanical, and alveolar. All three of them. And when we're talking about the Bohr equation, where we were measuring the VD-VT ratio, that's an E. Does that vaguely look familiar? Sure, Rick, whatever you say. Pico, pico, pico. So the arterial carbon dioxide level minus the mixed expired CO2 divided by the arterial CO2 will give you will give you a fraction, which is the VD-VT ratio. Normally it's somewhere on the order of 0.3 to 0.4 ballpark, maybe a little bit lower on the low end. A third of your tidal volume is wasted. How depressing is that? You know, you're sitting here breathing and a third of it. You know, why can't we be like frogs and just breathe through our skin or something? Wouldn't it be better? No. So, I know. This calculation, when I measure this VDVT, we're going to call this physiologic dead space. And that's a combination of anatomic and alveolar. What we don't measure with this is this mechanical. Because normally on a spontaneously breathing patient, there is no mechanical dead space. Unless you're underwater breathing through a snorkel, then there is. But that's a whole separate issue. Because we're not concerning ourselves with people who go in the water. That's stupid. If I combine all three of them, I'm going to call it total dead space. I use that term specifically. Since alveolar ventilation is how we control PCO2, I have the option of either increasing the respiratory rate or changing the tidal volume. Okay. PaO2 we talked about previously. We know that we can increase the FiO2 as one mechanism. We can also do things by altering the space under the table, that mean airway pressure, by increasing the baseline, increasing the end pressure or the delivery pressure, the PIP, lengthening the I time, or increasing the respiratory rate. Increasing, if I'm causing that pressure to be increased more often, the mean airway pressure is going to go up. Logic. I think you vaguely have seen this thing before. So, yes. Doesn't that make a bigger space under the table? I know where you're going with this. When we have a volume-based breath, or really a pressure-based breath, we're setting the pressure above baseline. So as I increase this from 0 to 5, this has to go from 20 to 25. You don't set these two things. They move together, yeah. When I say that I'm delivering at a certain pressure, it's always above the baseline. So if I raise the floor, it's got to go up higher. That's a great question, Liz. You don't know why yet, but when we talk about non-invasive ventilation, different story. Or in some neonatal ventilators, different story. So we're good so far, right? Nothing totally that you haven't heard before. Well, maybe a little bit of stuff. All right. This is probably one of the hardest concepts, I think, to understand. Really, a lot of, in pretty much any physiology. It just is a difficult concept for me to teach. So, but simply put, there is something called a time constant. And a time constant is basically how quickly the lung inflates or deflates when a breath is delivered. So an alveoli is being filled up. The amount of time it takes to fill that alveoli, or conversely, for it to empty, is dictated by the compliance and is dictated by the air resistance leading to that alveoli. What's the unit of measurement for compliance? Liters per centimeter water? Sounds good. What's your measurement for resistance? Liters per second per centimeters of water, right? So if I multiply that by that, if I multiply compliance times resistance, what unit am I left with? Liter goes away, liter goes away. Centimeters of water goes away, centimeter. I'm left with a time. That's basically what it is. How long does it take to inflate or deflate the lung? One time constant is basically that value. Now notice what happens. If I make my lung stiffer, if compliance goes down, what happens to the amount of time it takes to inflate or deflate it? It goes down. Think about a balloon that's really stiff. It deflates really easily. It's hard to get open, but deflates really easily. Somebody who has a high area resistance, on the other hand, is going to require a longer time. Tell me about my COPD patient. What about their compliance and their resistance? They have a high resistance. They have a high compliance too, don't they? Especially the emphysema patients, that component. So those patients have a time constant that is really high. What does that mean? Well, it means that I have to allow for extra time for them to exhale. Time constants come into play with that group of patients more so than pretty much anybody else. So those patients who have a high compliance and a high air resistance require a longer time to fill and empty. So when I'm setting up the ventilator, I want to allow for a longer expiratory time than I ordinarily would, because it's taking longer for them to exhale. Okay. Now, on a written evaluation tool, I'll probably ask you to calculate a time constant. That's a given. What does it mean? I have to calculate the area resistance, static compliance, and multiply them together. I don't know why this is such a hard problem to do, but people always
Give us the compliance and resistance, we have to calculate those two together.
Sha. Hello. Guess who just showed up? Yeah.
I figured it's worth a shot. Which compliance do we use?
Static. Always static. So what I would probably give you is I would give you a peak pressure, a plateau pressure, and a flow rate. And from that you can calculate the compliance and resistance.
The same that you used to give us on the other exams.
Oh, and a tidal volume, sorry.
Are
Yeah.
they set up the same way?
Yeah.
The examples you gave us in the lab portion, do you want us to multiply the time constant by 3?
Good point. No, for the matter of the test, I just want to know what one-time constant is. But normally we would need somewhere on the order of 3-time constants to be able to determine that 95% of our tidal volume is moving one way or the other. And then that's what this is kind of showing, that mathematically you need about 3-time constants to get the bulk of the gas in or out of the lungs. And that's what that is kind of showing us. Okay, I'll leave it at that. So, I think, boy, I'm not sure those page numbers are correct because I've updated it.
It starts at 96.
Is it 96?
Yeah. I think it's 4 pages, 5 pages.
So let's take a few minute break, and when we come back, we'll talk about, when we come back, let's meet in the lab. I'll make sure we get it set up. But there are some compliance case studies that basically go through all of what we talked about, calculating compliance, calculating resistance, looking at change in pressure because of compliance or resistance problem, blah, 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 blah. And then there's a lab that we'll do that will hopefully illustrate this to us. Okay, so take about 10. Not only can we talk about volume versus pressure-based breaths, we can also talk about there being negative versus positive pressure. Virtually all the stuff we're going to encounter in ICUs these days are all positive pressure breaths, but negative pressure was an option that we had also. We know that during spontaneous breathing, our respiratory muscles are the things that change intrapleural pressure, making it more negative, which causes alveolar pressure to become more negative, which causes airway pressure to become more negative, which causes gas flow to go into the lungs, with exhalation being a passive maneuver, right? It's way back when. And that's basically the graphical display that we looked at earlier, showing that. Positive pressures are obviously different. In this case, I'm creating a positive pressure at the airway, and as that airway pressure is increased, alveolar pressure increases, and intrapleural pressure really can, in some instances, actually become positive, but it certainly becomes less negative in the process. And that pressure that is generated is directly related to how much volume is delivered. The more pressure I use, the bigger the volume is. Again, when we're dealing with a pressure-based breath. We talked about positive pressure being volume-oriented or pressure-oriented, and we went through with that, and we'll come back and visit this over and over and over again. What we want to look at now is the difference between some of these negative and other types of non-invasive ventilation. First, let's talk about negative pressure ventilation. And this was designed to basically mimic the respiratory system that you and I breathe with. And the examples that are there are an iron lung, a chest cuirass, or a poncho ventilation. And when I show you these, you'll go, but a negative pressure is basically created around the outside of the chest wall. You're sucking the chest wall out. And the results of a negative alveolar pressure, because that gradient is established, air flows into the lungs. Once the negative pressure stops, the lungs relax, and the patient exhales. And that's basically what you end up having. This was an iron lung. You can't quite make it out, but the person would be here, and their body would be inside. And around their neck would be basically a relatively tight-fitting seal, so that as negative pressure was created here, the air would rush into their lungs. Okay. Anybody want to venture a guess what this is? It's a handle. Why? We lose power. Exactly. Exactly. Pretty scary. And it's basically just a big vacuum. That's all it is. Turn the vacuum on, create negative pressure, turn the vacuum off, goes back to zero.
So exhalation is passive with that?
Exhalation is passive. If you ever have an opportunity to get into an iron lung at a trade show or whatever, it's a blast. Because the only time you can talk is when the ventilator is creating that negative pressure. Or let me rephrase that. During the expiratory phase, when your air is emptying out of your lungs. If it decides it's time to take a breath in, you're talking, and then it starts back up again. So it's pretty wild. Here's a ward you can see where young child there inside of the iron lung, and again it was that polio epidemic that led to the mass use of iron lungs. This is an example of a chest cuirass. Basically, it's a turtle shell that goes on the outside of your chest. There's actually straps that go around your back and attach with Velcro to the front of the shell, and it's hooked up to a vacuum source that 12 times a minute creates a negative pressure. Air rushes in the lungs and the person breathes. And he could be on his laptop computer while he's being ventilated.
Looks like that would leak a lot.
No, still will. It'll still pull the chest out.
It seals the whole
Absolutely,
shirt.
absolutely. It's this gray portion here is like foam that actually will suck in. If you have a relatively tight fit, that vacuum will pull the chest out. No problem. But it allows a little bit, shall we say, portability that you're outside of the iron lung. This is a poncho, very attractive. Again, some tight seals around the neck and the wrists, and you ventilate somebody. It's an alternative method. So why would you want, or who would benefit from negative pressure ventilation? A lot of patients who have neuromuscular problems. They're okay perhaps during the day, they just need to be recharged at night. Just put them on a chest cuirass, and you're able to ventilate them. So any of your neuromuscular problems. A lot of the kids, by the way, at camp have SMA. That's spinal muscular atrophy, where basically the spinal muscles don't develop correctly, and that's one of the reasons they're in a wheelchair is they can't support themselves. It hurts their breathing. Diaphragmatic paralysis, the Ondine's curse, sleep-induced hypoventilation. Good thing about them, I don't need a tube. I don't need a trach. I'm using my natural airway. Huge advantage. When you intubate somebody or do a trachea, you're creating an open sore, a potential for infection, drastically reduced. They can communicate, they can eat, do all the things they normally would. Disadvantages, iron lung, trying to change the person for, doing body care. Got to break the seal to get in there. And you know what happens when you break the seal? You can't see them, so I can't tell if I'm developing peripheral edema. I can't tell if I'm cyanotic other than their lips. Medication administration is a challenge. And again, if you don't have good lower airway function and cough function, you can end up having risk of aspiration.
That's the disadvantage of the iron lung, not necessarily the other two.
Correct. Primarily talking about the iron lung, yes.
So how would they monitor the pulse ox, like a transcutaneous?
They could use something on the ear or forehead if there is a sensor designed for that purpose. So here I have this again, the negative pressure. You can see the negative pressure being created here. And the air goes in, goes back to zero, and the patient exhales. Same idea with the chest cuirass or the poncho. To me, the poncho is like ridiculous, but hey, you look at anything you can, especially on a patient who you want to send home. You want to do it non-invasively, these are your other options. Okay. Other forms of non-invasive ventilation that are not negative pressure. Okay. Non-invasive means I'm not using an endotracheal tube. First, let's talk about the pneumobelt. I've never seen one of these, but they are kind of a cool idea. Basically, it's like a, I don't want to say girdle, but something that goes around the abdominal cavity, has a bladder in it, so that as this inflates, and there you can see this fine young lady demonstrating the pneumobelt. As that bladder inflates, it pushes the diaphragm up, and the patient exhales. Relaxes, and the patient inhales. So it's opposite of a negative pressure ventilator. When that bladder's inflating, it actually is forcing air out, and it passively is allowed to go back in. With these kinds of things, we're not talking about somebody who needs full support. Obviously, they just need some assist on their breathing. Rocking bed. Again, I don't think I've seen one of these ever. But basically, as I tip the bed, head down, diaphragm moves up, air exhales. Tip the bed the other way, and the patient inhales because the diaphragm drops down.
10
So
times a minute.
10 times a minute, the bed is rocking back and forth. I'll take the pneumobelt too. I'm with you there. So this is why positive pressure was a little bit more of an advantageous mechanism, because I can establish a given tidal volume that's not variable. We can do this non-invasively. You can ignore this one. No, hopefully you'll never see it. But one on the left is the Respironics Vision, and the other one that we're going to utilize is the V60. They're both non-invasive ventilation, meaning I'm using some sort of a mask to be able to get a seal so they're able to be ventilated. Okay. Invasive positive pressure ventilators, there's a bazillion of them. The three that we're going to look at, the three we have in the lab, again, were the 840, the XL, and the Servo I. We do have other examples laying around here, so. But those are the three that you'll be responsible for. All right, let's talk about pressures. Now, up to this point in time, baseline pressure, I've said, has always been, we've kind of used the term PEEP interchangeably, right? What if the positive end expiratory pressure is set at 0? We call it ZEEP. 0 end expiratory pressure. And what do you think NEEP is? Negative end expiratory pressure. Okay. Someone came up with the brilliant idea, hey, if we're using positive pressure to push the air in, let's use negative pressure to suck the air back out. Didn't work. But there was mechanisms by which we could create negative end expiratory pressure. All it did was promote airway collapse, which was kind of defeating the process and going on. PIP, peak inspiratory pressure, peak circuit pressure, again, all means the same thing. It's a maximum pressure. It's measured within the airway. End inspiratory pressure is the pressure that we measure at the end of the inspiratory phase. Well, shouldn't that be the same as the peak? No. What happens if my peak pressure looks like this? Here's peak, here's end inspiratory. In theory, it's something like this where they're the same. Doesn't necessarily have to be, though. Peak pressure is defined as the highest pressure during the inspiratory phase, and the inspiratory pressure is the pressure at the end of inspiration. Steve?
How is that not expiratory? The end inspiratory. How is that not?
Here?
You're not exhaling.
You're not.
Back to the top.
You're not. This is all, gas is all going into the patient during this time frame.
So between the PIP and the end inspiratory pressure, you're still getting gas.
You're still getting gas movement in, yes.
Where does the plateau come?
If I create a zero flow condition, so given that example that we were just talking about, here's my plateau. Yes.
So that drawing that you did where the peak inspiratory is different than the end inspiratory.
This one here.
Yep. Is the reason for that, for the end inspiratory being lower, is that because the volume has why?
It's actually due to area resistance. It takes a lot of pressure to get past the resistance initially. After you get past it, it's easier to ventilate, so pressure goes down.
Okay.
You don't need to know that yet, though. But just know that there's a difference in terminology there. And plateau pressure we know about, okay? Sometimes that plateau pressure, by the way, is known as a static pressure. Same thing.
So the end, according to that top drawing, is the end before the plateau
This one does not have a plateau.
or the other one?
This one does not have a plateau. This one has a plateau. Yeah,
So
this is the peak. This is the end inspiratory. This is the plateau.
okay, so it's before,
Yeah.
so not all breaths are gonna have.
Oh, no. No, in fact, in most cases, we don't have a static pressure we don't have a plateau being displayed in most cases. What is the definition of a plateau? It's a period of time where I'm not allowing gas to flow. That pause that is there, zero flow. That allows that equilibration to happen and the different pressure to be displayed. Okay? I apologize for the terminology, being a little bit different. You just got to think it through. It'll get worse. So here's my PIP, here's my plateau. Now notice that that plateau is considered part of the inspiratory phase. Until airflow goes in the opposite direction and comes out, it's inspiratory phase. So the inspiratory plateau is part of the inspiratory phase. In fact, if you want to we can call this the inspiratory flow phase and the inspiratory plateau phase.
If you don't have a plateau,
Then all you have is inspiratory flow.
so how do you get your static pressure?
Well, you would have to create a pause. It's the only way you can measure it is to create a pause. And you'll just love me because each of the three ventilators is done differently. Oh, and by the way, for your PE, you will have to tell me what the static pressure is in compliance and resistance. I know you are.
So not every patient, you'll sometimes have to create a plateau pressure?
Absolutely.
Okay.
Yeah, we normally do not use a plateau pressure.
Okay.
Okay, so I see my baseline pressure here. I see my PIP. In this case, the PIP happens to be the same as the end inspiratory and my plateau. Contrast that with a spontaneous breath. Spontaneous breath means that I have a drop in inspiratory pressure and a rise in positive pressure to exhale. So this is inspiratory, this is expiratory. Notice also that I'm at a pressure of +10. That my inspiratory and expiratory phases are oscillating around a pressure of 10. If this is all I had, I would call this CPAP. Right? And for those geeks out there who want to be ahead of the game, if I combine a mechanical breath with a spontaneous breath so that we're allowing both to occur, that's got a fancy name called SIMV. You may or may not remember that. Synchronized intermittent mandatory ventilation. More on that later.
So your end inspiratory pressure isn't showing any slope on that graph?
The peak inspiratory pressure and the end inspiratory pressure is the same, yes. I
That
think.
immediate drop into the plateau?
Yeah, whenever you create a pause, you're going to have a drop from the peak to the plateau.
There could be a slope in there if your airway resistance was high to start with, opened up.
No. If I had an air resistance problem, the shape of this would be totally different. But let's not worry about that for now. I got more on that later. Okay, we know that pressure that is generated during a volume-based breath, we got to overcome compliance, we got to overcome airway resistance. So those two things have to be dealt with. And that's what's going to cause the patient to do additional work. And this is that graph that I showed you earlier, that I drew. But this is a far prettier one because it's out of your book. Okay, so you can see the peak inspiratory pressure rising, creating a plateau, demonstrating the difference between the two pressures. And we can say that part of that is resistance, part of it is compliance, or elastic, if you will. All right. Let's go ahead and, it's kind of early for lunch, isn't it? Not for you? That's all that really matters. All right, let's do this. Let's come back then at about 12:05. Is that good? And we'll back on track. All right, first thing we need to do is we need to obviously take the old circuit off the patient that was there, and we're always going to assume that it's contaminated because it is. Especially if you're using a circuit that has a heated humidifier that's wet, you got a source of growth there in the process. Virtually all the circuits you'll end up seeing are probably going to be disposable, although there are some institutions, I used to do it when I was a manager, that used reusable circuitry and processed it either through pasteurization or through steam autoclave. The circuit, but most of them are disposable plastic, like we have in the lab. Okay. Why would you choose one over the other? Why would somebody want to reuse a circuit? Cheaper. Bigger upfront cost, but they'll last years and years and years with reprocessing. Disposable, it's easy. Swap it out and you're done. We're going to wipe the outer surface with coagulant and disinfectant. So we're not going to, basically, you can't immerse the ventilator inside some sort of, inside the Pastormatic. It wouldn't do well. A lot of the touch screens are very sensitive as far as what they can use. Sometimes it's just as simple as using like a Windex or something along that line to clean the glass. But there are some substances that we have as cleaners that are abrasive, and once that gets scratched, it doesn't work really well as you can imagine. It's like putting your iPhone, doesn't work well. So once we go ahead and disinfect, there are some stuff that we may need to sterilize. Some stuff can just be cleaned, some of the parts and pieces. High-level disinfection is probably what most that we end up using. You guys know about the different types of processes. Just got to be careful to use the correct one. You got to just basically look at the manufacturer's recommendation. This is an example of a single patient use filter that was put through steam autoclave, and the heat kind of did a little bit of damage to it. That's not what it's supposed to look like. And the key part is to notice this. Well, what does that mean?
No second issue.
Can't use it a second time. It's a single patient use, SPU. Okay? So, oops. I was at a clinical site and they showed me that. I said, oh wow, can I have that? It's pretty cool. So we can go ahead and we know that there's different levels of processing that are there for different categories. Primarily what we're looking at is either the non-critical or in some level the semi-critical. We don't, as far as, unless you're doing bronchoscopy, don't get into the critical component. The gas source, all ventilators that we have in the lab here, and really most of the ventilators on the market, require two gas sources. If you notice, the ones that the kids were on didn't have any gas sources. They basically have an internal turbine that generates the flow. But our purposes for our critical care ventilators, typically you need a 50 psi air and a 50 psi oxygen outlet. Often they'll alarm if it gets below 35 or 40, so they can operate a little bit less than that, but that's the ideal, and your wall pressure should be 50 psi. How do you know what the wall pressure is, by the way?
They just
Okay, you go to the dial and you look. It's very, very simple. So if you get an alarm that goes off because you've lost gas source, go and take a look at the zone valve and you'll be able to tell what the pressure in the area is. Some of the units have internal compressors that can be activated if the air pressure falls or if there is no air pressure. If you look at the bottom of the 840, I'll show you there's an air compressor there. Not all of them come with that. It's actually extra money, so if I don't need it, it doesn't make sense to buy it. When I was at what was Bon Secours at the time, they remodeled the ER but failed to put in compressed air. I said, "Great guys, it just cost me an extra $3,000 a ventilator because I had to buy compressors with each of them." Was not happy. Can also have an external compressor. There's a really fine looking external compressor that is there. But basically, when we do some of the labs in the fall, I think Mary has some of the compressors utilized. Key part is whenever you have compressed air, you need to have a water trap in place, because once that air starts to cool, it's going to condense out and you'll get water. We've actually had situations back when we were at Providence. There was one wall that during the winter it would get so cold, and then when it warmed up on those 1 days or whatever, the compressed air line actually had water physically in it. So you'd plug in a flow meter and water would rush out. Well, better a flow meter than a ventilator, because you start getting water inside the ventilator, not a good combination. All of them also need to not only be pneumatically powered, did I mention that word by the way? Pneumatically powered, electrically powered. The electrical power usually is not so much to run the machine, to generate gas flow. It's basically there to control the circuits and the monitors and displays and whatever. Some ventilators have have a battery backup that will power the ventilator if you lose power. Some ventilators don't. Okay, so it really depends upon the manufacturer that is there. Gas flow always has to be filtered prior to going to the patient. There's a couple different filters that you end up having. One, where the 50 psi line hooks up to the ventilator itself, where it screws on, and when we go through, you take a look at them. Behind that, there's a small brass filter. We don't change them. We don't worry about them. They're Biomed takes care of that. But it's basically there to get large particulate matter that might be stuck inside the wall someplace. We also then have a main flow inspiratory filter. Most places utilize, some places don't, but you're basically using a high efficiency filter to filter it once again. And there are some ventilators that have filtering of the exhaled gas also, which when you think about it probably is the smartest thing. If your patient has any kind of respirable disease, you don't want to have that just being dumped into the atmosphere without going through a filter of some kind. There also is a fan filter that is present. So the ventilator, if you think about it, is this big electrical piece of equipment. It gets hot. So you need to have something to cool it down. But the air has a lot of dust in it. So you want to have some sort of a filter that removes the dust and other crud that's in the air prior to getting inside the unit. It's called a ventilator fan filter. And the same thing would be true if the unit has a built-in compressor. It'll have a fan filter also, and I'll show you that when we get in there. And then thirdly, if you're adding in some flow to power a nebulizer for breathing treatment, there could be a filter there also. Talked about these brass ones and the HEPA filter. Key part to remember with these is that these filters work by filtering. Meaning that they trap particles. So eventually, a filter's efficacy goes down because it's being clogged up. But as it's being clogged up, it also increases the airway resistance. So it's a double-edged sword there. I'm filtering the gas, but in filtering it, I'm also potentially increasing the airway resistance. Most ventilators have a self-check internally that they'll be able to determine if that filter is going bad and what you need to do about it. Okay. Most of these main flow inspiratory filters are easily sterilized if they're reusable by using steam autoclave, and it'll say on the filter it'll have that little 2 with a line through it, meaning it's a single patient use, or it won't, which means it can be processed. The process is steam autoclaving, not using gas sterilization with ethylene oxide. Key part. What's the step when you use gas sterilization? What do you need to do? Did Mary talk about this?
You rinse it.
Not so much rinse it. Well, you got to rinse the surface of it, yes. You got to let it aerate, right? You got to let it just get to a point where whatever gas is there is vented off. Well, with the filter, it'll never vent. In about 10,000 years, maybe it'll be done, but we don't have that long a time between patients. I'm going to skip this because I don't really. We're not going to do this in the lab or anything, so we'll skip through that. And again, we talked about the fan filters. They just basically are dust protectors. So it's a real difficult process. You take them off, you shake them off, you run them under some water, let them air dry, and put them back in. The 840 is kind of unique. It doesn't have, although it has an internal electronics, it uses what's called a heat sink to remove heat. It basically draws all the heat off and allows the atmosphere to do it. So here's an example of a ventilator cooling filter on the Draeger. Just a little blue filter on the back. You pull it out, shake it off, remove the dust, put it back in. It's not anything coming in contact with the patient, but again, if it gets clogged, just like your filter on your furnace at home, do you guys know you have a furnace filter on your? If they're not changed, eventually it's causing more wear and tear on the furnace, or in this case, the ventilator fan, because it's blocked off. So you want to be able to clear it off. And in the process, then it doesn't cool, and it can overheat, and when the electronics get overheated, bad things happen. And since this is a life support device, you kind of don't want to have bad things happening. Just saying. Here's the heat sink on the 840. It's just a piece of metal. I can show you that for what it's worth. And there's my compressor cooling fan filter. Again, just wash in soap and water and let them air dry. No big deal. Oxygen analysis, they should be analyzed whenever you have a change in FiO2 or at least once a shift, and they should be calibrated also. Many of them have built-in oxygen analyzers already built into the ventilator, so it's kind of academic. And then humidification is another key part that you want to, because we're bypassing the natural airway, we want to humidify any gas. Key thing here are those two values, at least 33 degrees centigrade and at least 30 milligrams per liter of water, which equates to about a 70% of body humidity at body temperature, which means that you still have some humidity deficit that the body has to compensate for. So that's kind of what the clinical practice guideline on humidification recommends. So there are multiple humidifiers that will have, on your final PE, I will tell you either to use an HME, use a booster HME, or use a heated water bath. And it really depends upon how mean I am. So these first three are what we end up having. Does Mary still cover heated circuits in the fall? Okay, so she'll talk about this last point here, where you actually have wires inside the circuit that keeps the temperature constant. It's kind of cool. But our heat moisture exchangers, our heat moisture exchanger with a booster, and I'll show you what that is, in our heated water bath. This is out of Egan, telling you which one you should not use, and these are important. Why you would not want to use an HME. Okay. How does an HME work? It's a sponge, right? Yeah, it just takes the humidity, takes the heat, stores it, and gives it back on the next breath. Two different types, hygroscopic, hydrophobic. I don't care that you really know that. I'm not going to ask you stuff on that, but I do want you to understand how how a HME functions. And there's probably, I don't know, 50 different brands out there. Some of them are absolute crap. Some of them are halfway decent. Obviously, the ones that are halfway decent are a little bit more money. So that's why sometimes you see crap ones out there. Is that mechanical dead space? Yes. Goes between the Y and the patient. This is just showing the different types, the hygroscopic versus the hydrophobic. They both function in the same fashion that we retain. This is a slide you may want to put a little star by, because these are the instances where you will not use an HME. First one is obvious, thick secretions. They need thick secretions, they need to be hydrated. Probably more systemically, but they are more prone to having mucus plugs develop if we're not using adequate humidity. And HME it's okay for a standard patient, but if somebody's got a lot of thick secretions, that's not an optimal option for use. Same is true with a lot of bloody secretions. If you have a leak present, a bronchopleural fistula, problems with the endotracheal tube or tracheostomy tube cuff. Remember, how do these things work? They take the gas that's being exhaled by the patient, storing the heat and humidity, and giving it back. Well, if I have a huge leak, there's no gas going back into the HME. So it's not going to be able to retain anything. And it's going to be inadequate for the subsequent breath. Patients that are drastically cold, patients with high minute ventilations or really low tidal volume, same thing, because it's a large dead space that is there. And the question always comes up with, and Mary will talk about this in the fall, what do I do if I'm giving the person a breathing treatment? Well, you can't have it so that the breathing treatment is, here's my nebulizer, right? Teed in. Here's my HME. Here's my patient. What's going to happen? Yeah, it's going to be filtered out by the HME. So if you're going to use that, this needs to be placed here. It's common sense, but oh, good God. I don't know how many times I've walked into a room, saw it placed like that. Booster HME. Booster HME works, and you should have in your packet a directions for use that explains how this works. But basically what it does is, this is a standard HME, or not a standard, but it can be used by itself as just an HME. It also has a small area, a small little heater. This is a heater. And this is a little drip chamber with an IV bag of water. And what it does is it slowly drips in some water onto the surface of this heater and adds some additional humidity. It's on the side that's going to the patient, and when we go through it in the lab, it says right on it, patient, so you know which side to hook up to your patient connector, and what side goes on the Y. And then finally, there's a heated water bath. I think Mary probably talked about the wick versus the membrane. Both are functional. The wick just draws up the humidity, so any gas passing by becomes humidified, where the membrane just passes, the dry gas comes in, goes over the surface of this. This membrane is hydrophobic, but the water vapor is allowed to pass through and is picked up, and you humidify the gas in that fashion. And got to be careful of the condensate. Again, I may have 100% relative humidity at the outlet, but by the time it goes through the room to the patient, it cools enough that you collect condensate in the process. And part of the problem is I got all this water. Let me get my, wrong one. Got to have blue for water. all this water collects in the circuitry. I then lift this portion higher than the patient, and it runs into the patient. I have now lavaged them with condensate. Not a good idea. So you got to be careful if you're using that. And that's why we use some heated wires to prevent that rain out, that condensate from happening. And I'm going to let Mary talk about that in the fall. And you can see the wires inside the circuitry. Need to go with that. Sometimes there's a water feed system where a reservoir constantly refills the humidifier. The downside to that is that if the little valving mechanism that opens and closes to allow for refill gets stuck, you can flood the circuitry, which would not be a good thing either. Every circuit, let me rephrase that. You really should use a different size circuit for pediatric versus neonatal versus adult. And it has to do with the compressible volume that you're dealing with. Adults, we're going to be a little more leeway. Kids, and especially neonates, you have to be a little more precise. I don't expect you to know anything other than if you're using a pediatric patient, you're going to use a pediatric circuit. And in most of the ventilators, you'll actually tell the ventilator that I'm using an adult or I'm using a kid. Okay. So, you should be able to, on each of the ventilators, trace the flow from coming out of the ventilator, going to the patient, and back again. And every ventilator will have an outlet. It's coming out of the machine, and then we're going to filter that gas when it comes out. It goes through an inspiratory limb, which may or may not have a humidifier in line with it, or it may have the HME. Going to the patient Y, to the patient, and back through the expiratory limb. And once it gets back to the ventilator, there's a couple of things that are there. One, there is something which pulls the gas back into the machine. It may have a filter there, it may not. But there's two components that are there that you'll need to be made aware of. One is an exhalation valve that opens and closes and allows the gas to be delivered. The way these ventilators work is if I close the expiratory valve and the gas is coming out of the inspiratory side, it's got nowhere else to go but into the patient. Once the gas has been delivered, I want the patient to exhale, I open up the exhalation valve and they're allowed to exhale, just like your IPB system was. In addition to having a valve there, you need to have a flow sensor. And the flow sensor is monitoring the volume that is being passed by, so I know what my tidal volume on the exhaled side is. This exhalation valve, by the way, is also how PEEP is created, because it keeps a small amount of pressure in there. That's just basically what I was talking about. The exhalation valve opens and closes. When it's open and allowing gas flow to go past it, we can measure that flow. All the exhalation valves we're going to utilize are all internal. We don't see them unless you take apart the machine. Well, I shouldn't say that. On the Draeger you do, and on the servo you do. But a lot of them, they're internal and you don't even see them. Old days, we had the IPB circuit. They had an external valve. And this is kind of the flow on the 840 coming out of the machine. Through a filter, to my humidifier, to my patient. There's my patient. And then back again through an expiratory filter and basically dumped to the atmosphere after that. All right, let's talk about that concept of compressible volume. As I mentioned, when a tidal volume is delivered from the machine, it puts out a set amount of tidal volume. Some of that volume, though, doesn't go to the patient. It just stretches the circuitry. So there's a small amount of what we're going to call compressible volume that's lost. So ultimately, the delivered volume is whatever is set from the machine, set on the machine, less whatever is lost, okay? The ventilators know this, because when we go through our self-test, it's going to calculate what that compressible volume is. What it will do then, it'll say, hey, wait a minute. I know that I need to deliver 800 milliliters. I know that my circuit loses 2 milliliters for every centimeter of water pressure, and this is what when it's going through its self-test, it determines that value for that circuit with that humidifier. Okay. It says then, okay, I deliver a breath and I see my tidal volume is 30 centimeters. To deliver my tidal volume requires 30 centimeters of water. How much compressible volume is there? What? Well, if you take your, and let's say I have PEEP as 0. Well, let's say PEEP of 5. So this is my PIP, this is my PEEP. What's my delta pressure? 25. So I take my 25, my delta pressure, times my compressible factor, this thing. I'm losing 50 milliliters. Does that make sense? For every centimeter of water pressure I generate, I lose 2 milliliters. I'm generating 25 centimeters of water, therefore I'm losing 50. So what does the ventilator do? Ventilator says, well, I'm not delivering my 800. I know what I'll do. On the next breath, I'll deliver 850 coming out of the machine, knowing that I'm losing 50 in the circuitry. Okay, so it automatically, each breath updates itself based upon the last peak pressure to say how much of that volume should be adjusted for. It does it automatically, and all three of them do that, yeah.
So it says that it delivered 800 even though it delivered 850
Yes.
for the last year.
No, it's compensating for the fact that there is some compressible volume. I wouldn't call it a lie. You're so mean. You're so rigid, Stephen. You gotta come out of that shell. Mel,
Will we calculate this on the exams?
I would assume that a problem like that would be a fair game
Okay.
at some point.
So, okay. So you're always going to find the delta pressure and then you multiply it by,
Whatever the factor is.
okay.
It's not rocket science.
Yeah.
And I'll show you on each of the ventilators how to determine, I can't, what that compressible volume is. You can skip these two slides because we're never going to do that. But this is exactly with the formula we were talking about. Compliance, huh? The methods for determining compliance factor and this example. If you had a ventilator that didn't compensate for it, this is the way you would do it. But the three that we have in the lab is not an issue. So yeah, my peak pressure is 40, my PEEP is 5, therefore my delta is 35. 35 times my 2.82 will give me 98.7 milliliters is lost.
Ventilator tells you the, where was it?
The compliance factor?
Yes,
It calculates that during its self-test, yes.
always.
Always. Well, yeah, always.
Okay.
On the servo, you can turn it off. I don't know why the hell you would ever want to do that. But that's assuming that you don't change the circuit or change the humidifier. If you do, you need to recalculate it. Because that humidifier actually has compressible volume also. So, got to take that all into account. Talked all about dead space. I'm not going to go anything further beyond that. We just know that dead space is bad because it's wasted ventilation. So you're adding some space in there. It's potentially putting some additional work on the patient. Okay. Lastly, we want to talk. I think that's lastly, right? We're almost done. Something called an operational verification procedure, or what I call checking it out. Is the ventilator functional? What ends up happening in most institutions is somebody brings the ventilator back down, strips it down, cleans it, processes it, puts it back together, does a check on it, puts a little sticker or something on it, and puts a bag over it, puts it in a corner. 3 days later, that ventilator is now needed. Then we go ahead and just pull it and assume, bad word, we assume, sorry Steve, that the operational verification procedure has been performed. Okay. On the 840 and on the Draeger, and I think on the Servo also, all three of them will tell you when the last one was done. So you kind of get an idea. What it looks for is it looks to make sure the machine, because again, this is a piece of silicon, right? Want to make sure that, it's functioning. Last thing you want to have is a ventilator that malfunctions. So is the computer working? It detects for leaks in the circuitry, so if there's something where some connection isn't tight, it'll tell you that. It'll tell you if your circuit's functioning, especially if you have an external valve. It also will then go ahead and measure, on some of them at least, what that circuit factor is, the compliance, the compressible volume factor, what the resistance of the filters are, and will verify that all the alarms are working. And that should be done before each patient use. Usually, like I said, it's done and stored. And if you do change the ventilator circuit, as I said, you need to recalculate the compliance factor in the process. On the 840, it's called SST, short self-test, and we'll walk through on each of the three how they're done. And then finally, there's some emergency operating states that what happens if the ventilator malfunctions? What does it do? Well, at the very least, it should be able to open the valve to atmosphere. So that one where it says safety valve open, any mechanical ventilator sold, the FDA says, if this fails, you need to open a valve to the atmosphere so the patient can breathe. Minor detail, right? Even though it's spontaneous ventilation, even though, they may need the support, you need to at least have them be able to access it if something fails internally. Second one is apnea ventilation. All the ventilators have a mechanism where if you're in a spontaneous mode, patients just breathing on their own, the ventilator is just kind of sitting there monitoring them. If they go apneic, it should kick in. Let me back up. It should alarm, hello, and ventilate the patient for you until they start breathing again. You'll see this a lot with drug overdoses who are kind of in and out, in and out, in and out. When they're in, they're breathing fine, then they kind of go back out and they stop breathing. The ventilator should kick in and ventilate for them until they start ventilating again. There actually was a ventilator on the market that alarmed but didn't do anything. That helps out a lot. Airway pressure disconnect or circuit disconnect, you want to have something that if the ventilator becomes disconnected, you are alerted to that. It's one of the more serious things that ends up causing patient death, is an accidental disconnection that goes unnoticed. Not a good thing. And then backup ventilation is available on most of them, that in case there's something where we lose power, it'll reset itself and ventilate the patient in some backup settings. And at the bedside, you got all kind of crap that you're wanting to have available. Different places do it differently. Although the clipboard with paperwork is becoming less and less because it's all now EMR. And most of the EMRs end up having it so that you walk up, you touch a button, and it downloads all the information from the ventilator directly into the computer system. How sweet is that? Always, 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 unless you want to do mouth to tube, have a bag that's functioning at the bedside. Just saying. And what I would always tell my nurses is, if it's alarming, you don't know what's wrong, the safest thing to do is take them off and bag them. Can't hurt. So, there should be Lab 9 somewhere in there, which is dealing with ventilator assembly and operational verification. Let's go ahead and go back to the lab. Well, let's take a few minute break so I can get set up in there.